shows like the clotting factors and what actual materials in the body is used. So like you see, I mentioned like the precipitating event, so the trauma or infection, because also bacteria can cause this, and then a ruptured cell releases like the tissue factor, and then that starts off the coagulation cascade, which starts producing excess thrombin. And then you can see here the two different pathways that it can go to. Like you have the excess clotting, which makes clots and then can produce ischemia, or you can use up all and go into shock from hypovolemia, I think. Okay, next one. Okay, so yeah, as I said earlier, in DIC, the cascade is not regulated, and it results in in systemic clotting and bleeding. So you bleed from everywhere. Yes, the precipitating trauma causes the release of tissue factor into the plasma from cells, where it signals the body that there's been trauma and starts the clotting process. And then excess floating thrombin causes small clots to form all over the body, and platelets aggregate to the clots, making them bigger. And once the clotting factors run out, there's nothing left to stop bleeding from occurring. And yes.
Okay, so the body system's affected. So as we have a lot of small blood clot formations, which either lead to hemorrhaging or the ischemia, it can also lead to necrosis and organ damage, which affects the respiratory system, the cardiovascular, the neurological system, GI, GU, and integumentary, which the specific organs that this affect are the lungs, the heart, the brain, the liver, and the kidneys. So manifestations of DIC, I don't know what happened. There we go. So we have the subjective data, which, as we know, this is what the patient complains about. So we have chest pain, shortness of breath, pain in the affected limb, headache, dizziness, and double vision. For the objective data that we can measure, we have erythema, warmth in the affected area, swelling, hematuria, hematochezia, petechia, uncontrolled bleeding, cyanosis, decreased capillary refill, hypoxia, hypotension, tachycardia, altered level of consciousness, and as well as changes in the speech, behavior, or confusion. So signs and symptoms of excessive clotting, we have headache, dizziness, altered levels of consciousness, hypoxia, and then changes of speech. And all of this can be a common indicator of a stroke. For people that have deep formations of the clots in their deep veins of their lower extremities, you'll see pain, warmth, arrhythmia, and swelling. Chest pain, shortness of breath, cyanosis, and absence of air movement during auscultation of the lungs can be a common indicator of an embolism, and this can be seen in both acute and chronic DIC. So signs and symptoms of internal bleeding, we have hematuria and decreased urine output, which can be an indicator of decreased perfusion to the kidneys, whereas hematochezia, if we have darker colored stools, this can be a common indicator of a bleed in the GI tract, whereas the bright red stools may indicate bleeding or of hemorrhoids or anal fissures. And then if we have a headache, double vision, or seizures, this can be a common indicator of a brain bleed. Signs and symptoms of external bleeding, this can occur from either underneath the skin, an opening of the skin, or mucosal membranes, which can produce purpura, petechia, prolonged bleeding during simple procedures such as IV access or venipuncture, as well as nosebleeds, brushing teeth, shaving, or minor cuts. And in women, you can also see extended menstrual bleeding or menorrhagia. So In petechia, this is more smaller, non-blanched red spots, and this is from intradermal bleeding, whereas purpurea, you're going to see larger raised dots, and this could be just from the bleeding within the skin. So for diagnostics, we're going to see decreased platelet levels within the CBC, a blood smear, which will determine the destruction of red blood cells. We're going to see prolonged PT and PTT, decreased fibrinogen blood tests, and an increased D-dimer. So for the treatment, am I going into someone else's, or is this my slide? Okay, it's fine. Oops, sorry. So the treatment, as we said earlier, our goal is to determine and treat the underlying cause. Supportive measures include replacing the fluids and electrolytes, administering platelets and clotting factors, as well as packed red blood cells and plasma. Plasma transfusions are for the patients who have a lot of hemorrhaging and need to replace the blood clotting factors. Heparin is used as prophylaxis for those who also have excessive clotting, and antibiotics are used for sepsis.
Okay, so nursing interventions. You would assess for changes in the level of consciousness. The early signs of cerebral hypoxia are restlessness and irritability, and if the hypoxia is prolonged, the signs are confusion and excessive sleepiness or somnolence. When you assess for vitals, you have to assess for respiratory rate. You will normally see rapid shallow respirations. And this usually indicates hypoxia or acidosis in correlation with the shock state. DIC patients usually have blood clots that travel to the lungs and will cause the obstructive shock, and that's when you see the shortness of breath, the cyanosis, and chest pain. If hypoventilation is seen in these patients, immediate ventilator support is indicated. You have to also assess oxygen saturation. The O2 sat should be at least 90% or greater, and you have to administer oxygen as ordered. You would also have to assess heart rate. Normally with initial hypoxia, you will see tachycardia. You would assess breath sounds. So you would auscultate the lungs, and any changes to breath sounds you should address to the provider immediately. You would assess cough and any signs of bloody sputum. Usually hemoptysis is an indication of bleeding in the respiratory tract. You would assess urine. Usually decreased perfusion to the kidneys result in hematuria and decreased urine output. So it's your job as a nurse to monitor I's and O's. And this is due to the risk of fluid volume deficit related to the bleeding. And, you know, because of bleeding, you do lose a lot of fluids. You would assess stool, and like Danielle said, dark blood in the stool indicates GI bleed, whereas if bright red blood indicates bleeding hemorrhoids or anal fissures. You would administer stool softeners as ordered. This prevents straining during bowel movements, and it prevents even more bleeding. You would assist with coughing, and you would suction as ordered. Having a productive cough is the most effective way to remove built-up secretions in the respiratory tract. If the patient is unable to cough productively, you have to suction as ordered to clear the airway, and this prevents the use of the accessory muscles and any sort of labored breathing. With DIC, you would monitor ABGs. Increasing PaCO2 and decreasing PaO2 are signs of hypoxemia and respiratory acidosis. Other ranges you would monitor for platelet count. Anything below 50,000 should definitely be addressed to the provider. You would monitor PTT. INR shouldn't be greater than 1.5. Fibrinogen shouldn't be less than 100 milligrams per deciliter, and hematocrit should not be less than 21%. If any of these levels go way above or below its respective ranges, it should be addressed to the provider. You have to change the position of the patient every 2 hours. This prevents pressure ulcers, and it also minimizes blood pooling or blood stasis. Blood pooling actually can cause clotting, and it can cause a thrombus to float around your system and travel to the lungs and like cause an obstructive shock. You have to move your patient every 2 hours. Moving the patient will also help move and drain the secretions in the respiratory tract. Along with positioning, you have to position the patient in high Fowler's position. The upright position will allow adequate diaphragmatic excursion. And what does that mean? It means that the diaphragm is able to move up and down, inflate and deflate the lungs effectively. And this also promotes appropriate lung expansion. And lastly, these are a couple of precautions that you have to take. So bleeding precautions, you cannot use razors. You have to use a soft toothbrush, and you have to limit the use of needle sticks. You have to make sure that the IV access is always patent and it's always maintained, because the more you prick at the skin, it's going to be harder to control the bleeding. And it's also very important that you limit BP readings and you do not use an automatic blood pressure machine, because it can cause bruising. Infection. So infection is one of the most common causes of DIC, and the patient normally requires antibiotic therapy. So you as a nurse, you need to follow very strict hand hygiene and any other precautions that are required, prior to entering the room. Along with infection, you have to monitor for the signs and symptoms of infection. So that's like shortness of breath, vomiting, and then you would also take seizure precautions, and any sort of activity should be reported immediately.
Okay, so patient education. It's very important for the patients to be aware of infection prevention, and how important that is. Good hygiene and proper hand washing and hand washing technique. Monitor temperature and notify their healthcare provider of any signs of infection. Patients should seek immediate care if they experience chest pain, difficulty breathing, or coughing up blood. They should monitor for heavy bleeding and bruising, and they should use a soft toothbrush. So a few of the things we found were, there was a study, recumbent human soluble thrombomodulin and mortality in sepsis-induced DIC. So this is a new class of anticoagulants that they're using in Japan to treat DIC. It hasn't been approved yet in other countries, but it did show a reduced mortality in patients with sepsis-induced DIC. And then the clinical investigation of coagulation markers for early detection of sepsis-induced DIC, a single center prospective observational study, basically just was going through, they studied coagulation markers such as soluble fibrin, plasminogen activator inhibitor, and D-dimer levels that could potentially enable earlier detection of DIC than the existing criteria. High plasma levels of soluble fibrin and plasminogen activator inhibitor may be used as indication of the development of DIC, and soluble fibrin may be used not only to predict DIC, but also to exclude the diagnosis of DIC.
Can you please go back to the previous slide and hold it there? Okay, give me a few seconds. Next slide, please. Previous slide one more time.
How do I make a box here?
Okay, good job. Let me just recap DIC. So the group showed the causes. So you can see sepsis is, DIC is not a primary disorder, right? It's a complication that results from various causes, and the causes mentioned are not minor. These are severe conditions. They mentioned sepsis, pancreatitis. You have here blood transfusion reactions, particularly hemolytic reactions, liver disease, because the liver, of course, makes the clotting factors of the body. So major trauma, cancer also. In the case of cancer, there's specific types of cancer, like say here mentioned is leukemia. They are, the reason here is cancer cells, if you were listening to the pathophysiology, when tissue factor is released, that triggers the clotting cascade. Tissue factor is a normal protein produced by an injured vessel. So you have several injuries there on the risk factors. Let's say abruptio placenta, you had trauma, hemorrhage, burn. So all of these are severe injuries. So they will cause injury to the blood vessels, triggering the release of tissue factor, which will again trigger the clotting cascade. So you have two problems here in DIC. You have the first phase is the clotting. So as you saw from the presentation, the patient presents first with a lot of clotting. And if you look at the slide number 6, so they showed the pathophysiology here. This is the clotting cascade. So there will be the common trigger here are again those risk factors mentioned, which lead to the release of tissue factor. Whenever you have tissue factor, you have the clotting cascade activated. I forgot to mention for the cancer cells, particularly leukemia, trigger the release of tissue factor in the absence of vessel injury, meaning there was no trauma, there was no injury to the blood vessel, and it's the cancer cells themselves that release the tissue factor, causing this clotting. So the patient undergoes microthrombi first. The clots here are not the same as other conditions wherein we have the DVT, PE, stroke. The other causes are usually from, let's say, whenever you have the varicose triad, there's increased venous stasis, there's vessel injury, and then there are hypercoagulable conditions. So here in DIC, the causes here are major trauma. The body undergoes a severe inflammatory condition. COVID-19 is another cause, or we should say a newly identified cause of DIC. So you may have seen in the news wherein the patients develop clots. So what they're developing really is DIC. So they undergo clotting, microthrombi, millions of tiny clots in the first phase of DIC, and then once, as stated in this figure here, once you use them all up, because you use them all up in a short period within hours to a couple of days, so you run out of your clotting factors and platelets because they're all gone because they now form clots. So now you have nothing to form clots with. So the next phase will now be followed by bleeding. So if you look at the DIC, you won't wonder why, oh, don't wonder why the mortality is so high. It's so hard to manage. In the first place, during the clotting phase, the only thing you can do is give heparin. And then, of course, all the while, you're treating whatever was causing this. So this is going to be a very busy patient, to take care of, because for one thing, the risk factor that triggered it was major in itself, and then you have to deal with this. The first phase is the clotting, and then followed by bleeding now. So it's a very complicated condition. Most people, unless identified early, though, you can still manage this if identified early. And they did look at, I mean, the group did show the diagnostic testing that will help you recognize and treat DIC sooner. So that will be on the exam, all your lab results, namely fibrinogen, platelet count, D-dimer, PTINR. All right, so those labs that they, right here, this slide right here, and it's also in your textbook. So these are you watch for, meaning if you have any of those patients listed under risk factors, those are the very patients that you monitor for DIC for. So you look at their blood studies every day to make sure they are not developing DIC, or if they are, then you notify the physician right away. All right, and you guys did have a study from Japan, which was interesting. Okay, any other comments, guys? All right, let's go with the next group. Who's willing to volunteer?
We are going.
All right, go ahead.
Professor,
Yes.
before that other group goes, I have a question really fast. I just got an email about this ExamSoft thing that we only have until 9 a.m. today to download the mock exam. So should we do that now?
Well, I already, I thought you guys did it because when I looked at you guys are complete. You've already
You
created
just
your.
have to hit download, Nikki. It takes like 10 seconds.
Okay, so we just download it and then that's it?
Yeah, it's no big deal.
Okay, that's my only question.
Alrighty, you can do that in the background. All right, next group.
Trinissa.
Hold on, I'm coming.
We're just waiting. Okay, no problem.
Oh my God. I don't know how this works. I'm trying.
Papa,
Yes.
how do I make this smaller? I'm trying to make a text box.
I guess share screen. Can everybody see it? Hello?
Yeah.
Okay.
Okay, should I start?
Yes.
Yeah.
Okay. Good morning. Our group also did a bleeding disorder. It's called idiopathic thrombocytopenic purpura. It's also a bleeding disorder that has a lot to do with platelets and clotting. And yeah, this is the table of contents. So we're going to cover, we're going to cover a case study. And then we're going to talk about what idiopathic thrombocytopenic purpura is. It's also, ITP is short for it. The anatomy, diagnostic tests, lab values, pathophysiology, the clinical manifestation, nursing diagnosis, nursing intervention, medical management, current research, evaluating goal outcomes, and references. Next slide. To start off, we have a case study. Sheila, a female with no medical history, came to the emergency room. She complained of pain when urinating with increased urination. She was first diagnosed with a UTI and was prescribed macrobid. She had no known allergies, and within days, her symptoms cleared up, but she began having epistaxis episodes and ecchymosis on her arms and torso. She returned to the emergency department, and upon discussing her new symptoms with the ER attending, a complete blood count or CBC was drawn. Her results came back: white blood count 5.5 normal, hemoglobin normal 13.2. There was an abnormality in her platelets, which was at a level of 45,000. She had a stat consultation with a hematologist for further evaluation of ITP. Next slide.
What is idiopathic thrombocytopenic purpura? Idiopathic thrombocytopenic purpura, IT, which is called ITP, is an immune disorder where the blood doesn't clot normally. Thrombocytopenic results from immunologic platelet destruction. ITP has two distinct clinical syndromes: an acute condition in children and a chronic condition in adults. And the picture shows the PTK on the patient. So that's one of the signs you will know if you having ITP. Okay, the anatomy. Idiopathic thrombocytopenia purpura is related to platelets. They are small colorless disc-shaped cell fragment without a nucleus. Platelets are found in large numbers in the blood and are involved in clotting. When these platelets production are decreased or increased, it causes complications to happen. One of these conditions is hemorrhage, which leads to idiopathic thrombocytopenia purpura. But the main complication is the risk of bleeding. And on the right, you see the platelet. You see the platelets where it's small, and when it's activated, it produces the fibrin, and then that's the pathway that it takes.
Okay. Diagnostic tests that are recommended is blood tests to check on the platelet count. The test usually includes a complete blood count. In ITP, the red blood cell counts are normal, but the platelet count is low. A blood specimen smear, a microscope is used to look at platelets and other blood cells. Blood tests for antibodies that attacks protein. Bone marrow tissues can show whether bone marrow is making enough platelets. Okay, lab values. Prolonged bleeding time and coagulation time is considered when diagnosing ITP. However, the main test used is complete blood count, which focuses primarily on platelet levels. These are the normal platelet levels should be in a patient that doesn't have ITP, which is from 150,000 to 450,000
per microliters, and for thrombocytosis platelet is 450,000, and thrombocytopenia platelet count is 150,000.
I don't see the next slide.
You don't see it?
No, it's slower for mine. Okay, I see it now. Okay. ITP usually follows a viral infection or immunization in children. In adults, ITP may be medication induced or secondary to an autoimmune disorder. In all cases, it appears to be an immune system dysfunction in which antiplatelet antibodies are formed, which increase platelet destruction. It went back again.
Sorry.
Rather than the 7 to 10 day lifespan, the platelets may be destroyed in a matter of hours. The number of circulating platelets is greatly reduced in ITP, even though platelet production is normal. Patients who have this disease in their body has made antibodies against the surface of their own platelet, an antiplatelet antibody. This antibody coats platelets surface, making destruction of macrophages easier. The spleen has many macrophages, and the blood vessels of the spleen are long and twisted. These conditions increase destruction of the antibody-coated platelets in the spleen. When platelet destruction exceeds platelet production, the number of circulating platelets decreases and clotting is impaired. This is the pathophysiology of ITP. The body produces antibodies, like explained in the other slide. The body produces antibodies against platelets, and it leaves the platelets to be destroyed, leading to purpura, which are like small purple dots that occur when blood leaks onto the skin. Next slide.
This is also the pathophysiology on the platelets, the pathophysiology of ITP in kids. Clinical manifestations, that's the signs, PTK, reduced platelet counts, ecchymosis, non-palpable spleen, spontaneous bleeding, hemorrhage, purpura. Many patients have no symptoms. Easy bruising, heavy menses, and mucosal bleeding, and platelet clock is generally below 20,000 micromilliliter.
Okay, nursing diagnosis. The nursing diagnosis is risk for injury due to bleeding related to decreased platelet count. Another one is risk for effective therapeutic regimen management related to possible frequent administration of platelets and clotting factors. Fear related to hemorrhaging from low platelet count. Risk for infection related to immunosuppression caused by immunosuppressant therapy. Also, risk for the deficient fluid volume related to blood bleeding caused by low platelet count. Okay, nursing intervention. Platelet count lab results on CBC will specify if low platelet count is related to increase or decrease in platelet production. Ecchymosis, the more susceptible to bruising/trauma, increases the risk of injury and low platelets. Purpura, these manifestations should be monitored because of reduction in platelet. Frank bleeding, which is epistaxis, gum bleeding, GI bleeding, or hematuria. The anatomy where these occurs are prone for bleeding.
Nursing interventions continued. Safety, maintain a safe environment, clutter-free. It helps protect the patient from bleeding. Minimize blood loss. In case of bleeding, direct pressure and or ice application to stop the bleeding. Avoid intramuscular injections. This procedure can increase the risk for bleeding. Minimize blood draws. Blood drawing should remain at a minimum. Avoid rectal temperature. Enemas, suppositories, douches. These can eventually lead to bleeding. Medical management. Treatment with glucocorticoids can decrease antiplatelet body production, leading to increased production of platelets by the bone marrow. Platelet transfusions may be required to control significant bleeding, but is not recommended for prophylaxis. Transfused platelets also have decreased circulation, and repeated platelet transfusion may lead to platelet on immunization or an immune response to non-self antigens. In hemophilia cases, the clotting factors are delivered via IV in combination with recombinant DNA products. Prompt treatment with clotting factors minimize complications caused by bleeding such as joint deformities, which were prevalent prior to factor replacement. Medical management continue. Corticoid, prednisone can suppress the activity of your immune system, which can increase platelet count. Rituximab, this is an antibody therapy which destroys the immune cells known as B cells, responding for producing the proteins that attack platelets. However, it's unclear if this treatment has long-term benefits. Thrombopoietin receptor agonist includes romiplastin, which aid bone marrow in producing more platelets. They also help prevent bruising and bleeding. This has been approved by the U.S. Food, Drug, and Administration Department for the treatment of low platelet counts due to chronic ITP. General immunosuppressants inhibits the overall activity of the immune system. They don't target specific components of the immune system related to ITP. These include cyclophosphamide and azathioprine because they have significant side effects. They are often used only in severe cases that haven't responded to other treatments. Shanisa.
Okay, intervention. So you gotta educate the patient and their family on the disorder and bleeding precaution. Educate the patient on recognizing the importance of reporting bleeding to the primary care provider. Teach patients to adhere on risk in the decrease of platelet. Caution patient on taking aspirin or drugs that cause impaired coagulation. Advise patient to carry medical identification stating disorder of ITP. Teach patient to always examine skin for ecchymosis and petechiae. Teach patient to take medication at all time as prescribed. The importance of frequent laboratory testing, which monitors of thrombocytopenia. In recent years, research on immune thrombocytopenia has greatly improved. Understanding its pathology is a key component in its diagnosis. Management and treatment. There's evidence to prove that platelet production in patients with ITP is abnormal. However, recent research suggests that megakaryocytes in the plasma of ITP patients demonstrate abnormal growth. Megakaryocytes create platelets in the bone marrow. Scientists cannot assume that this disease can just be traced back to platelet production, but rather an issue with the patient's bone marrow. While improvements have been made regarding diagnosing ITP in patients, significant gaps in available data, including lack of data and or centers on second-line therapies and optimal management of chronic ITP still exist. This lack of data leads to uncertainty and prevents levels of optimal management of patients to be researched. Current diagnosis of ITP is established with careful history and physical examination, as well as review of the peripheral smear and minimal further testing. Because of ITP can be secondary to other conditions, other options include testing hemoglobin levels with other autoimmune disease can lead in its diagnosis, but can be is not always helpful in the absence of symptoms in adults with uncomplicated new diagnosis of ITP. Previously, a splenectomy was an option for treatment in patients with persistently low platelet count. However, new forms of treatment are now being looked into as the safety and efficiency of splenectomy are being questioned. These new developments include novel therapies such as oseltamivir phosphate. A single small study and 2 case reports have looked at oseltamivir phosphate, a sialadase inhibitor developed to treat influenza, as a potential therapeutic option in ITP. Further examine the role of this platelet clearance mechanism in ITP.
Evaluating goal outcomes. In the previous case study, the goal for Sheila was to prevent hemorrhage or bleeding. That she will report no signs of bleeding, and she will show no signs of petechiae, ecchymosis, or hemorrhage. Patient platelet count can be improved within the normal range.
These are the references.
And these are our references. That's it.
Please hold
We're
this.
done, Professor.
Next slide, please. Okay, thank you. Just a short summary. So ITP is autoimmune disorder. So the body develops antibodies against the platelets. That's why you saw one of the contraindications was a platelet transfusion, because the platelets, the more you give platelets, then of course that will trigger another autoimmune response. So they will just be destroyed anyway if you give more platelets. Plus, how bad does the platelet count drop here in ITP?
Very low.
Give me numbers.
Like 20,000.
Okay, so as
40,000.
described, right, so management will be similar to any of the conditions well, in the case of DIC, there were both there. There was clotting and bleeding. For this one, there is bleeding, right? By the way, for the pronunciations, they're called PURPURA, and it's also called petechia, hematochezia. Yeah, those were just a few pronunciations that I noticed. Anything else you want to add for ITP? That was interesting though, the one you shared about because most patients with ITP end up with splenectomy, because the theory is, since the spleen's the one really that's destroying the platelets, so it's better to take it out, right? But it was interesting with the current research you are proposing. I mean, you found that uses that drug instead, although the study was limited. It was a very short study, but it was interesting. Okay, next group.
Thank you.
Thank you.
Hello?
Hi.
Okay, my group will go next then. So my group is me, Israel, Vivian, and Donna. We will be talking about heparin-induced thrombocytopenia. Donna, are you able to share it? The
Yeah,
screen?
just give me 1 second.
All right.
Are you able to see it?
Yeah, I see a screen.
Do you see the PowerPoint?
Yeah.
Yes.
Okay.
All right. So what we will be discussing is heparin-induced thrombocytopenia. And as I said, the group members are myself, Israel, Vivian, and Donna. Okay, so the systems in which the disorder affect. Heparin-induced thrombocytopenia is a condition that affects mainly the arterial system and the venous system, also known as the circulatory system. It also affects other organs such as the kidneys, the lungs, GI, the brain, and it also affects the mucous membranes. The circulatory system is responsible for delivering oxygen and many nutrients to different organs and cells in the body via the blood. The blood then travels throughout the circulatory system and body and have platelets in it. The platelets that are in the blood are responsible for forming clots, which can prevent you from bleeding, and it also forms plugs and blood vessel injuries. Heparin-induced thrombocytopenia affects the platelets that are in the blood, causing you to have a low platelet count, which can increase bleeding. The pathophysiology of heparin-induced thrombocytopenia. Heparin-induced thrombocytopenia is caused by antibodies in your immune system that bind to complexes of heparin and platelet factor 4, activating the platelets and promoting a prothrombotic state. The antibodies bind to the platelet factor 4 heparin complexes on the platelet surface and induce platelet activation by cross-linking receptors. The activated platelets increase the release of platelet factor 4, creating a positive feedback loop in which further release of platelet factor 4 promotes further platelet activation. This platelet activation and the formation of platelet microparticles, which initiate the formation of blood clots, cause the platelet count to be decreased in the blood, leading to thrombocytopenia. So here's a diagram. This is a figure of how it's actually happened. The pathophysiology of heparin-induced thrombocytopenia. So as you see, number one, the heparin binds to the PF4 and acts as immunogens. Then number two, the IgG antibody thus forms PF4 heparin and IgG multi-molecular complex. Then it goes to number three, which is the complex that binds via FC receptors to platelets and activates them. And then 4A, you have activated platelet releases additional PF4. And then you have the prothrombotic microparticles at 4B. And then at stage 5, you have the immune complex interact with the endothelial cells and promotes immune-mediated endothelial damage. So for the pathophysiology of heparin-induced thrombocytopenia, It occurs when patients who is receiving heparin has a decrease in the platelet count, which falls below 50% of the baseline count, which results in bleeding. This happens about 5 to 14 days after exposure to the heparin. Most individuals possess pre-existing and active platelet factor 4 and heparin-specific B cells, and that breakdown of tolerance can lead to the production of platelet factor 4 and heparin-specific antibodies. These heparin-induced thrombocytopenia antibodies can be found in plasma in more than 90% of patients with the clinical diagnosis of heparin-induced thrombocytopenia. And this is also another diagram of how it actually happened. The different stages is basically the same thing that was in the other slide. It's just more colors and prettier. All right. The general clinical manifestations is the first manifestation that you see. The first stages of manifestation is like easy bruising and petechia. And then the other clinical manifestation is epistatus, GI bleeding, which is black and tarry stool, bleeding of the gums, hematuria, that's blood in your urine, and in severe cases, cerebral hemorrhage, bleeding in your brain.
Specific clinical manifestation. There are two types of heparin-induced thrombocytopenia, type 1 and type 2. Type 1 is reasonably common and it is present in the first few days following a patient exposure to heparin. The patient platelet count falling to 100,000. 150,000 is the first manifestation of the disorder. This is the non-dangerous complication exhibited by a lack of bleeding on thrombotic complication. Type 2 is the unusual form of HIT, which is an human-mediated. Type 2 HIT is characterized by the patient platelet count falling about to 50,000. And more noteworthy is that the platelet fall by over 50% from the baseline within 5 to 10 days of heparin therapy. The second clinical manifestation of HIT is thrombosis, which is characterized into two, venous and arterial thrombosis. Venous thrombosis can lead to serious, in some instances, deadline pulmonary embolism, which can necessitate a patient undergoing amputation. Arterial thrombosis can lead to myocardial infarction, cerebrovascular accidents, as well as limb gangrene. There have been reported incidents of thrombosis in graft artery, splenic artery, and mesenteric artery. Another less common but specific manifestation of HIT compromises of necrotic skin, lesion of the spot where heparin was injected into the body. The final manifestation of HIT is bleeding. Although bleeding occurs rarely, it has been described to come from intracranial, retroperitoneal, and GI and adrenal sites. The patients with HIT are more prone to bleeding complications. This is a picture. This is a picture of a patient with HIT. You see the fingers, how it looks like, the toes and the leg. General clinical manifestation. The first clinical manifestation, you will see easy bruising, petechia.
We're on the wrong slide. We're doing 11.
Oh, I'm sorry. Okay, I'm sorry. Nursing intervention. It is important to assess platelet count. Decrease in platelet count is seen on the CBC. Ecchymosis, ease of bruising and tissue injury increase with contact. Petechia and purpura, and intradermal bleeding. Frank bleeding, you will see mucous membrane are more prone to bleeding. The nurse should minimize blood loss from laceration, venipunctures, avoid intramuscular injection, avoid rectal temperature, enema, suppository, provide safe environment, use minimal inflation when assessing blood pressure, minimize blood draws. The nurse should instruct the patient on bleeding precautions. The patient should avoid sexual intercourse when platelet is less than 50,000. Teach the patient on the importance of frequent CBCs to monitor thrombocytopenia. This is the precaution, the bleeding precaution for the patient with thrombocytopenia. So the patient has to use a soft bristle toothbrush, use an electrical razor for shaving, encourage use of shoes for safety, maintain a clutter-free environment to minimize bruising, use a stool softener daily to decrease constipation, and avoid rectal thermometer, suppository, enema, and vaginal douche. Avoid sexual intercourse when platelet count is extremely low. Do not blow nose. When using a knife, it's necessary make sure blade is sharp. More force is required for dull knives. Go to the next, please. Other interventions. Once a patient is diagnosed with HIT, all sources of heparin need to be suspended and alternate and different heparin anticoagulants should be administered instead. The selection of which non-heparin anticoagulant to use usually depend on the availability, cost, presence or absence of renal or renal insufficiency.
So currently there are 2 alternatives for non-heparin anticoagulant available. Direct thrombin inhibitor, which reduce the activity of thrombin. Anti-factor XA, which inhibits thrombin generation. So the DTIs comprise of piperidine, argotropin, and bevacizumab, but the only 2 are the FDA approved. And for the first intervention pertains to acute and active HIT patients with thrombocytopenia, HIT antibodies, and thrombotic complication. Patients taking any DTIs, should not only be given in any platelets transfusions. Non-heparin anticoagulants, particularly piperidine and argotropin, need to be administered for at least 2 weeks. During this period, the patient should be under special monitoring. During instance of renal and hepatic insufficiency, the dose should be regulated depending on the drug's metabolism. Once the patient's platelet count rise to about 150,000, oral warfarin can be introduced with careful corresponding of DTIs for at least an additional 5 days. The nurse should adhere to the recommendation on monitoring the patient's transitions from DITs to oral warfarin. If a patient requires life-sustaining procedures such as CABs, PCI, and or hemodialysis during the HIT phase, the selections of DITs will depend on the availability, monitoring facility, standing orders of the healthcare facility. The secondary intervention relates to the patients with subacute HIT, where platelets have recovered and are stable with count of about 150,000, but patient continues to have detectable HIT antibodies. The reintroduction of heparin is to be avoided for about 100 days due to the increased risk of thrombosis and acute anaphylactic reaction. On the other hand, non-heparin anticoagulant may be used to tie over CABs and PCI or hemodialysis. The risk for developing thrombocytopenia varies throughout the lifespan of the individual. In addition to the type of heparin, other risk factors are associated with age. HIT increases with age and varies and very rare among children and young adults. Gender, HIT is more common in women than men. Studies show that women are twice likely to develop HIT as men. Also, patient type. Surgical patients are at greater risk of HIT than medical patients. HIT are rare among pregnant women. This is what they follow to evaluate a patient that could be at risk for HIT. It's called a 4T score, which is a risk score taking clinical and laboratory information into account. The 4T score result in a score of 0 to 8 points if applied to a given patient with thrombocytopenia or falling platelet counts. HIT should be considered unlikely if the resulting score is equal or lower than 3 points. If the 4T score is greater than 3 points, HIT is moderate, 6 to 4 points, or very likely for 7 to 8 points. And laboratory workup should be initiated to eventually rule out of HIT. There are a number of laboratory tests that are available for type 2 HIT. One of them is the C-serotonin release assay, which combines serum from a suspected type 2 HIT patient with platelets of a normal donor and adds them to a therapeutic concentration of heparin. And if it's a positive result, it would have the serotonin release from the serum suspected from the patient. Another assay is the heparin-induced platelet activation assay, which assesses the aggregation of platelets induced by the serum of the patient who who has who in the presence of heparin. Another one is platelet-rich plasma, and the last one is the HIT specific antibody, which detects IgG, IgM, and IgA. It is important to note that a patient may have type 2 HIT with negative laboratory results. Therefore, in patients suspected with type 2 HIT who have negative laboratory result, the diagnosis is usually made clinically. This is due to the fact that adverse sequelae may occur with this condition, and an alternative anticoagulation strategy may need to be initiated promptly. Some other treatments that are still being studied, although it may seem intuitive to transfuse platelet to a patient with HIT to control bleeding, or for prophylaxis secondary to thrombocytopenia, treatment guidelines prior to 2010 warn against platelet transfusion. And because of the limited evidence available, the ACCP guidelines does not recommend routine platelet transfusion for patients with HIT. However, they do support the transfusion for severely thrombocytopenic patients with HIT who are bleeding or in necessity for transfusion during the performance of an invasive procedure with a high risk for bleeding. A drug that's still being tested but not approved yet is bivalirudin, which is a DTI that affects on both free and clot-bound thrombin and does not bind with other plasma protein. And unlike heparin, which is reliant on antithrombin concentration, bivalirudin does not need a cofactor to function. So in addition, bivalirudin inhibit platelet activation and adhesion by decreasing circulation von Willebrand factor and by directing an attenuating thrombin receptor mediated activation of platelets. So although it's not approved as a treatment for HIT, several retrospective studies have evaluated its therapeutic role in this patient population and support it as a possible alternative. And some important stuff is that it is important to remember that HIT could increase in APTT, INR, ACT. So it's very crucial to have those laboratory results to avoid any complication or failure, treatment failures. According to the ACCP guidelines, the transition of warfarin therapy is required for 3 months in patients with HIT and 4 weeks for those with isolated HIT. The guideline also recommend delaying the initiation of therapy until the platelet counts have recovered at least 150,000, because concurrent thrombocytopenia may reflect the ongoing thrombotic state of HIT. Further evidence suggests an association between warfarin therapy in patients with HIT and venous limb gangrene. These patients commonly represent with super therapeutic INRs from severe protein C depletion. Thus, premature cessation of heparin anticoagulant agent before the therapeutic effect of warfarin occurs and increased risk for a new thrombotic event. This is critical to overlap the non-heparin anticoagulant agent with warfarin. That's it.
Do you only have one reference page? This is it.
Yes.
All right, to recap, thank you guys. Heparin-induced thrombocytopenia is now increasing because we're also increasing the use of heparin. So more and more people are using or receiving heparin. So the incidence is also rising. So this makes your job a little bit harder. This is one more thing you have to watch out for. So all patients receiving heparin must be monitored for HIT. As the group described, there are two forms. There's one that will develop right away, and there are those that develop later. The reason for this is it takes time for the body to make antibodies, meaning when you receive heparin today, as described on one of the slides, it takes 5 to 10 days before the IgG antibodies develop. So let's say somebody was just admitted for a couple of days. Will they have HIT during the admission? Let's say they were there for a surgery. No. Okay, so but it doesn't mean they did not develop the antibody. They did. So let's say this is the first time, let's say Jesslyn is admitted. So Jesslyn came in there for appendectomy. So she was discharged the same day because it was laparoscopic. She's a young girl, so she tolerated the pain fine. She can walk. So she was discharged later in the evening after surgery, early in the morning. She received heparin. Like I said, it takes 5 to 10 days for the IgG antibodies to develop. So she will not present with the symptoms today. However, since she has the antibodies already, and there were no subsequent heparin doses that she received because she was discharged, she did not develop any symptoms. Okay, but she has the antibodies now. Later, when she comes back in for whatever reason, she's hospitalized again, and now she's exposed to heparin again, she will develop the symptoms right away because she has antibodies already preformed from the first time she was admitted and exposed to heparin. You understand the difference?
Yeah.
There was a cute slide that Israel showed, the one with a cartoony pathophysiology. Okay, and then there was two things there, two little cute faces that said, "It's my first time." Okay, so that was the description of how it developed. So it becomes a cycle. So once heparin is exposed, it binds with platelet factor 4, which is recognized as a foreign object, and that's what triggers the antibody formation, because the platelet 4 complex formed with heparin is a foreign object, meaning it's not recognized as although the platelet 4 was produced by the body. However, when it bound with heparin and formed a complex, it's now unrecognizable. It's now considered a foreign object. That's what triggered the antibody formation. And let's say the patient developed HIT during the admission, right? Either from the same admission or a subsequent admission. So there will be the more heparin you receive, the more clots you will form, because each molecule of heparin will form a complex with platelet factor 4, which will activate more platelets, and then it becomes a never-ending vicious cycle of heparin complex antibody clotting, heparin complex. So it's caught in an unending cycle. So the platelet count drops because they keep turning into clots with every molecule of heparin. Now this is dangerous, right? Because why did we give the patient heparin in the first place? Hello? Why would somebody
to stop clots from forming?
Yeah, to prevent clots, right? But what's happening here when you have HIT?
It's actually forming it.
They're actually forming clots, which is dangerous, right? So therefore, that's why the first action is to stop heparin once you recognize it. And the most common symptom drop in your platelet count, right? Of 50% or more. Now, this may not be always evident, because if it drops by 50%, so let's say I came in with a platelet count of 450. When it drops by 50%, what is my platelet count? I started with 450,000.
It's 225.
225. Is that abnormal?
Yes.
225 is abnormal?
No.
Okay, that's my point. So will it stand out to you when you do your daily platelet monitoring? Will it turn red and bold?
No.
No, because it's normal. 225,000 is normal. 150,000 is your lower threshold. Only if it falls below 150,000 will it turn red and bold. But it doesn't mean the patient isn't having HIT, because there was a 50% drop. So I went from 450 to now 225. So this is I'm just giving you an idea. So when you're out working already, you're in a hospital taking care of a patient with receiving heparin, then they develop HIT, it may not be very evident until the platelet count drops below 150. But always look at it before. So always compare it. What is your numbers today? What was it yesterday or the day before? So if you see that big drop, then you notify a physician, because we have to stop the heparin. Because again, the more heparin this patient receives, the more clots they will form. But however, as the group also discussed, the patient needs anticoagulation, right? That's why they were given heparin. So what were the alternatives once we discover the patient has HIT? What will we use as anticoagulants instead? You guys kept talking about DTI. So direct thrombin inhibitors, give me the 2 examples you presented in the slide.
The lepirogine and the
Bipalidine, okay, and
the tragoban. I can pronounce
argatroban.
it.
Okay, so argatroban and bivalirudin. Bivalirudin is Angiomax. You see that frequently used in cardiac catheterization procedures. This is what they use to prevent clotting at the access site. So when a patient goes to the cath lab, either femoral or radial access, the patient will be given bivalirudin. That's Angiomax. So that's where, if you've never seen that drug, that's where you'll see the drug. That's what they use for cardiac catheterization. You never had platelet transfusion, right? Why is there no platelet transfusion in HIT? Does the platelet count drop significantly low?
Yeah, the platelet count do drop.
So how low though?
At first, like in order to actually diagnose with HIT, you got to drop at least 50%.
Yeah, so therefore, will there be a time that they will ever need a platelet transfusion?
Yeah.
I didn't see that in your presentation. Meaning the platelet drop. Yeah, go ahead. The platelet drop in HIT isn't really that low, meaning it drops by 50%. By that time, though, we already discover that the patient has HIT, so we stop. So the platelet count rarely drops below transfusion thresholds, meaning it doesn't drop dangerously low, because hopefully by the time it started dropping, we have already stopped the heparin. All right, unless it's a really incompetent, hospital that they don't recognize the HIT. But of course, it's a hospital, so we will discover and diagnose the patient already by that time. So the platelet count doesn't really reach dangerously low levels that will require transfusion. All right, good job, guys. Let's have the last group, TTP.
Okay.
Good morning, class.
I'm gonna be sharing.
Good morning.
Give me one second. Okay, can you guys see it?
We can see it.
Okay, awesome.
All right, so our group will be presenting thrombotic thrombocytopenic purpura. And in the group, we have Medisa, Yan, Richard, and Nicole. Can you move to the next slide?
Mm-hmm.
All right, no, the next slide.
The next one?
Yes. Okay. So just a brief introduction. Thrombotic TTP generally is a blood disorder which causes platelets to clump. Platelet clumps form in small blood vessels. Thrombotic TTP also leads to low platelet counts because of the platelet clump, and this can also affect red blood cells breakdown and other parts of the body like the kidney and the brain, and also cause heart dysfunction. TTP mostly is caused by triggers, but in most cases, like 50% of the cases, there are no identified triggers for TTP. Most of the common triggers for TTP are bacterial infection, medication, autoimmune disease, which is lupus, and pregnancy. The major underlying mechanism in all of these cases involves the antibody inhibiting the enzyme, which is the ADAMTS13. The next slide, please.
Mm-hmm.
All right, so TTP patients generally exhibit thrombocytopenia. This is due to the aggregation of the platelets, making the patients to become a little bit anemic, and there are some certain drugs that have been used as associated with TTP, and they are known to be associated with TTP, and they represent about less than 15% of the cases. And the drugs include quinine, vinblastine, trimethoprim, pegylated interferon, let's see the last one. It's minus something. Okay, can you move to the next slide? Okay, so this basically just talks about the pathophysiology of how TTP is formed. Before I go into the main part, this is just like a picture form of how the TTP is formed. On the right, you see that when the ADAMTS13 is attached to the VWF, there's normal circulating VWF multiliners. But when there's no ADAMT attached, that leads to platelet aggregation, and as such leads to tissue ischemia in the body and microvessels also. So this can cause other symptoms. This leads to major symptoms of TTP. The beginning factor is the two main players in this stuff are the VWF, the ADMTS13. So in the case, can you move to the next slide? Mm-hmm. So for most patients, in all cases, TTP is characterized by the VWF factor, and the VWF factor are rich microthrombi that affect the arterioles and capillaries of multiple organs. TTP is majorly caused by a deficiency of a plasma metalloprotease, that's the ADMTS13. We have the VWF and platelets form aggregates when exposed to high shear stress in microcirculation. The propensity to which microvascular thrombosis is mitigated by the ADMT13. That was explained in the previous picture, whereby you when the ADMT is not attached to the VDF, there's platelet aggregation, which can lead to thrombocytopenia. ADMT S13 cleaves VWF before it is activated by shear stress to cause platelet aggregation. The VWF platelet aggregations are large enough to form microthrombi, inducing stress, inducing tissue ischemia, platelet consumption, and microangiopathic hemolytic anemia. So the platelet aggregation leads to thrombocytopenia, and which can also lead to anemia, and can also affect other parts of the body, like some other organs of the body too. Next slide, please.
So I will move on and talk about the manifestation, signs and symptoms of TTP. According to the name, TTP is a type of thrombocytopenia. However, it's not a type of thrombocytopenia that is that severe, that will cause massive bleeding typically. Usually we will be looking at platelet count somewhere between 20 to 50,000 as comparing to the normal range of 50 to 100,000. However, it's pretty common to see symptoms of petechiae, as represented by the small dots on the picture, and the slightly bigger bruises, usually raised, as represented by the purpura on the right side of the picture. The purpura can be seen on the skin, and can be seen in mucous membranes as well. TTP will cause anemia, and that will be from the breakdown of hemoglobin. There are two indirect ways we can check the, next one. It can cause anemia. Usually the anemia is not very severe. I'm sorry, I'm still on the last slide. Usually, for male, the hemoglobin level is normal from 14 to 18. And for female is somewhere between 12 to 16. That's the C and D in terms of the eyes on the left picture. For TTP, we will be looking at somewhere between 8 and 9. So that's slightly better than the one in A in the left picture. That picture is a male with a hemoglobin of 7.3. And in B, for reference, that was 12.7. That's a mild anemia for a male standard. Another reference point is that we usually will require a blood transfusion if a patient have anemia somewhere 7 to 8 in terms of the hemoglobin. On the right, we have the comparison of the hands showing normal versus anemia for people with different skin colors. Next one. Because of anemia, there will be decreased red blood cells to carry the oxygen throughout the body, and the body starts starving for oxygen, and the patient will feel fatigue. Okay, next please. TTP will cause hemolysis with bilirubin as one of the breakdown products. And we know bilirubin will cause jaundice. Usually our normal lab value will be looking for under 1.2 for adults to be considered normal. You can start seeing signs and symptoms of jaundice, meaning yellowness of the color of the skin or the eyes at around 2 to 3. And for TTP, we will be looking at bilirubin level somewhere between 2.5 to 4. Another breakdown product or another indirect way of measuring hemolysis is ADH, which stands for lactate dehydrogenase. However, the elevation of it, the signs and symptoms are not too directional. TTP will also cause changes to vital signs. We'll be looking at pyrexia or fever due to the hemolysis. And because of anemia, we will also see tachycardia and dyspnea. Perhaps the most important cause of the TTP is it can, because of the decreased oxygen flow to the brain, it can cause headache, speech changes, confusion, coma, stroke, and seizure. Those are the more significant manifestations. In terms of your kidney, also because of decreased oxygen flow to the kidney, it can cause acute kidney injury. The picture shown here, it's both proteinuria, meaning it's cloudy, containing of a lot of protein, and hematuria, meaning it's kind of reddish color, have some red blood cells or breakdowns of it. And also because of the AKI, we will see some oliguria. In terms of nursing interventions, the nurse will be monitoring signs and symptoms of the TTP as we previously explained, and have performed frequent blood draw for CBC, mainly for the platelet, and then for the serum LDH. If the platelet is significantly low and LDH is significantly high, a patient might require an additional therapeutic plasma exchange than the original plan. And also, it's important to monitor the CMP for the bilirubin and the kidney function. The nurse will provide education to the patient and the family in regards to the signs and symptoms, as well as the bleeding precautions, which Nicole will explain further in detail in the next slide, and avoid sexual intercourse if the platelet is significantly lower than the 50,000. And they will need to follow up with their providers to frequently monitor their lab values. The nurse will also minimize blood loss from lacerations, avoid IM injections, avoid taking rectal temperature, putting enema, um, suppository, minimize blood draws, and use minimal inflation when monitoring blood pressure. Okay.
So the bleeding precautions that Yan was referring to in the last slide are: one, to use soft bristle toothbrushes, no flossing, to use electric razors for shaving, to wear shoes or slippers when out of bed, to maintain a clutter-free environment to minimize bruising and falls, to decrease constipation, avoid rectal thermometers, suppositories, enemas, and vaginal douches, to not blow your nose too hard. When using, only use knives when necessary. Wait, what does that say? When using a knife is necessary, make sure blade is sharp. More force is required for dull knives. If a laceration occurs, directly apply pressure, ice for no less than 5 minutes until the bleeding stops. Procedures such as intramuscular injections, arterial sticks, and peripheral blood draws should be kept to a minimum. I also want to add, when you are talking to a patient with TTP, to advise them against the use of aspirin and ibuprofen. Both can cause severe bleeding. And as for the current treatment options, when I was looking them up, a lot of the studies that I looked at were either discontinued or withdrawn. So the ones that you see here are the ones that are the finished. So we have plasma therapy for TPE, which is therapeutic plasma exchange. It is the cornerstone of TTP management. TPE is performed daily until manifestations such cerebral manifestations, renal failure, increased troponin levels, abdominal pain all have resolved. The platelet count should stabilize and hemolysis should cease. This is a daily treatment. And then there was a study done for steroids in Ohio State University in 2017. It shows that cyclosporins and prednisone can be effective in the treatment of TTP. And the rationale behind this is the autoimmune nature of the steroid. And then we have rituximab. The study was done in Emory University on February 14th, 2020, and it found the medication to be effective against for TTP. The medication is used for more during the periods of exacerbation, and it causes a rapid decrease in the B cell production. And then for the last one, we have N-acetylcysteine. The study was done in Puget Sound Blood Center in Seattle, Washington, in July 2017, and the drug inhibits platelet adherence and reduces the size.
Okay, so for current research, there was a drug presented to the FDA for the specific treatment of TTP. The name of the drug is capilacimab, and it targets the A1 domain of the von Willebrand factor and inhibits the binding of the von Willebrand factor and the platelet glycoprotein receptors. And so this basically prevents the formation of the microvascular thrombi and platelet loss associated with TTP. So the trial that was done was called the Hercules trial, and it was published in the New England Journal of Medicine by Dr. Marie Scully and her colleagues. And this was an international study that was double-blind, placebo-controlled, randomized study designed to evaluate the efficiency and safety of the drug. And the primary outcome was the time of normalization of the platelet count with the discontinuation of daily plasma exchange within 5 days of treatment. So the patients recovered from TTP in a shorter amount of time with the help of the other treatments available. The secondary outcome included a decrease in composite of TTP-related death, reoccurrence of TTP, or a thromboembolic events during the trial treatment period, reoccurrence of TTP at any time during the trial, and refractory TTP, and normalization of organ damage markers. So on February 6, 2019, the FDA approved this drug for adult patients with acquired thrombotic thrombocytopenia purpura in combination with plasma exchange and immunosuppressive therapy. So this is our resources reference.
Is it only one slide?
No.
The next one, please.
Okay.
Okay, thank you.
You're welcome.
All right, to recap, TTP was pretty clear, but the gist is the patient lacks the ADAMS 13 gene. So therefore, there will be inappropriate clotting as a result because there's no more formation of the von Willebrand factor. So the patient will form clots inappropriately for no reason, but because they used up all the platelets in the process. Therefore, when they do need to clot, there's no platelets left to form a clot. And that's basically it. The summary for all of these are in page, in chapter, whatever this is, 34, hematologic disorders. So check under thrombocytopenia. So you'll see all 4 disorders there. So you have DIC, HIT, TTP, and HIT. DIC, of course, is also discussed in chapter 14 under shock, under septic shock, because it's a natural consequence of sepsis. But the rest of it are all on on chapter 34. Okay, so exam questions will come from chapter 34. Especially the labs results, the findings, and 2 groups presented box 34.2 for bleeding precautions. And those are further described in in the nursing care on page 700 and 701. All right, so here's the box that you guys referenced, and here are the complications, which begins with hemorrhage. The thing about chapter 34 is they jumbled everything together rather than talking about them separately. So they just put them here in separate paragraphs, but they're all in one section. So under medical management, for instance, they just separated them into paragraphs, but they're all in one area. Same thing also with the clinical manifestations as well as the pathophysiology. Any questions, guys? Any questions on the blueprint for next week?